Sleep disorders is an exceptionally common condition, and there are so many different types. It's always a challenge with this lecture to decide what not to include. The official classification of sleep disorders, there are 85 different types in 8 major categories, and so we're just going to go for the highest yield, most common disorders in this lecture. Just kind of as a big picture before we get into this, if we look at the main contributors to insomnia, we see lots of common things. Depression is actually the #1 contributor to insomnia. Obesity, increasing age, as we'll discuss in this lecture, your sleep gets lighter as you get older. And so especially you have that, along with maybe a man who has benign prostatic hypertrophy who needs to go to the bathroom, and so the quality of sleep diminishes with age. And also medications that are on board contribute to insomnia. So here's just a little sampling. A lot of our GABA medications, so remember if you activate those, that can be helpful for some things like epilepsy, but that's going to contribute to some drowsiness during the day and insomnia at night, or if we have something that activates GABA, that could also be a problem. A lot of the seizure medications can contribute to insomnia. Antihistamines we've talked about, beta blockers, if you're using dopaminergic medications like for Parkinson's, that contributes to insomnia. If someone is withdrawing from stimulants type medications, and just the evening medications, even ones that are used to help with sleep, there can be a rebound effect from those. So always we need to carefully look at the patient's medication list to see if that could be contributing to the difficulty sleeping. Medical conditions like diabetes would be kind of our classic example, interferes with sleep. Smoking and sleep apnea, which is really common as people get older, especially if they're overweight. Why do we need to have a good sleep at nighttime? And we could have a whole lecture just on that, but I'll mention 2 factors. We know that sleep is important for clearing these waste products that accumulate in the brain, including amyloid beta, our subject of an Alzheimer's disease from last week. So that's important. And also, I will tell you, we'll go through the different stages of sleep, but during stage 2 sleep, in particular, there's good evidence now that this activity we can see in the brain during stage 2 sleep is actually the brain consolidating memories, making long-term memories from short-term memories. And so sleep is very important for that, and that's why I'll kind of remind you when we get into this, but when you're studying for an exam, really you want to get a good sleep the night before to try to consolidate all of those memories. We've discussed before these ascending arousal system, a network of neurotransmitters that project largely from the brainstem. So for example, the locus coeruleus and raphe nuclei here that produce norepinephrine and serotonin, these are really active during wakefulness. So is dopamine, histamine from the hypothalamus, acetylcholine from the base of the brain, glutamate, orexin. And so these are largely stimulatory neurotransmitters, so I wouldn't worry too much about the difference between these up arrows, but when we say the ascending arousal system, these are the neurotransmitters, and especially I would say for these first 3, you need to know the areas specifically that are involved in producing those neurotransmitters. Now, during sleep, we'll divide into non-REM sleep and REM sleep, and we can see that during non-REM sleep, there isn't really any production of dopamine or acetylcholine from the pons or orexin. And during REM sleep, the main thing to highlight here is that acetylcholine projections from the pons, from the reticular activating system, there's a subset of those neurons that are really active during rapid eye movement sleep. And remember, this is, you dream during all stages of sleep, but we remember the ones during REM sleep. And so dopamine kind of think of, we've talked about dopamine with hallucinations, so kind of makes sense we're going to have some dopamine activity during REM sleep. So I would really highlight here orexin is extremely important, as we'll discuss in this lecture, produced by the hypothalamus. And notice that shuts down completely during non-REM and REM sleep. And orexin in particular, when we're active, when we're moving, there's a lot of orexin released. And so that's why it's, if you've ever noticed driving a car and you're drowsy and you shake your leg or tap your hand on the steering wheel, that's very alerting. Well, what you're doing is you're releasing orexin, which stimulates wakefulness. Okay, so you'd want to take that away from this diagram, and also remember acetylcholine from the pons is the most important in terms of activity increase during the REM stages of sleep. All right, so what happens in this transition between wakefulness and sleep? Well, there's a very important area here, a part of the hypothalamus called the preoptic area. Okay, and there is a more lateral portion called the ventrolateral preoptic area and a more medial portion called the medial preoptic area. Okay, but in terms of the ventrolateral area, this area inhibits all of these areas here in the midbrain and the pons that are part of the ascending arousal system. All right, so it will shut down, for example, areas that are releasing dopamine or norepinephrine or serotonin. So this is very important. This is overactive during sleep to shut down all of these areas of ascending arousal system. So here is the ventrolateral. If we do a section here through the hypothalamus, here's the ventrolateral preoptic area, okay, and here is the medial area. And it turns out that when you're getting drowsy and feeling like, boy, I need to sleep, that is the medial preoptic area, okay, and it activates the ventrolateral preoptic area to actually then help to facilitate sleep. So we think that the medial preoptic area is especially important for induction of sleep, that kind of initial drowsy feeling, and then throughout the night the ventrolateral preoptic area is active to keep you asleep throughout the night by shutting down the ascending arousal system. Okay, so again, the ascending arousal system, then when you're waking up, it becomes relatively overactive and inhibits the ventrolateral preoptic area. So this is what happens when you wake up in the morning. So there's this tension between the ventrolateral preoptic area and the ascending arousal system, and this really does work like an on-off switch, which is a good thing, because if it didn't happen like that, we'd have hours of transition between falling asleep and waking up. But instead, when we fall asleep, it's very quick. And when you wake up, there's a little bit of grogginess, but we're alert and awake quickly. So this really is, we think of as an on-off switch. Now, the other very important area that relates to all of this are very close to the ventrolateral and medial preoptic area are these orexin-producing neurons here in the hypothalamus. And so orexin, otherwise known as hypocretin, is the one that is active when you are active, when you're walking. I mean, it's impossible to fall asleep standing up or walking, right? Because the orexin neurons are really active, okay? And so they will act here to stimulate the ascending arousal system, okay? So kind of does the opposite here of the ventrolateral preoptic area. And so again, in this kind of off-on switch, we have the ventrolateral preoptic area, which is active throughout the night when we're sleeping. We have areas of the ascending arousal system here, like the locus coeruleus, the raphe nuclei. And so the orexin is an important input to this. When orexin, when we're active, it's going to stimulate the ascending arousal system and we're awake. All right, but the ventrolateral preoptic area, when it becomes more active and shuts down the orexin-producing neurons, then they can't activate then the ascending arousal system, and you fall asleep. Okay, so the orexin and the medial preoptic area and the ventrolateral preoptic area and the ascending arousal system, these are kind of the four main components here in terms of transition between sleep and wakefulness and vice versa. Now the suprachiasmatic nucleus, which we see right here, this is kind of the biological pacemaker, and it sets the circadian rhythms. And circadian rhythms are extremely important in terms of setting sleep-wake cycles, determining when we're hungry, temperature regulation, and also the production of melatonin. So light here has a direct connection to the suprachiasmatic nucleus. There's a retino-hypothalamic pathway here, okay? And so light or dark has a different effect on the suprachiasmatic nucleus, which actually feeds into the sympathetic pathway. So we've emphasized this pathway for Horner's syndrome that goes all the way down to T1, T2 of the spinal cord, and then goes up to the pupil and Mueller's muscle. But notice this pathway here going through the superior cervical ganglion also has a connection with the pineal gland. And so in the absence of light, this pathway stimulates the pineal gland to release melatonin, which contributes to setting the circadian rhythm. Light stimulation shuts down the production of melatonin. So that's why when you're traveling, it can be helpful, especially if you're flying to Europe or something like that, to take melatonin before sleep to help to facilitate a resetting of your circadian rhythms. Now I'm going to talk about the testing that we do for sleep disorders at the beginning, so we can kind of refer back to this when we talk about various sleep disorders. So we do three things during sleep testing. We record the patient's brainwave activity, EEG. We do an electrooculogram, where we put an electrode on either side of the eye, because it turns out the cornea is a little positive, the retina is a little negative, and so by putting electrodes here, we can see what the eyes are doing. And we do EMG, usually over the submentalis muscle. This is not with a needle in the muscle, but we can put a surface electrode over the muscle. So notice here, I said you don't need to know specific EEG patterns for epilepsy outside of absence seizures, but you do need to know the different frequencies of brainwave activity. The alpha rhythm, which is 8 to 13 hertz, this is a rhythm we see when someone is awake. And not to get too technical, but when we're doing an EEG test, we see this when someone closes their eyes and they're awake, and we see this nice alpha rhythm. That tells us they're awake. Beta rhythm is actually something we usually see kind of as a medication side effect. And so in terms of wakefulness and sleep, it's really the alpha, theta, and delta which are most helpful. When somebody becomes drowsy and they're starting to fall asleep, they go from having an alpha frequency to a theta frequency. And in the deeper stages of sleep, the brainwaves slow down a lot, and we see this delta frequency. All right, so during sleep, we go through 4 stages. The initial, when you first fall asleep, you go into stage 1 sleep. So remember, that goes from alpha to a theta rhythm. Stage 2 sleep is really important. About half of sleep is stage 2. And during stage 2, we get 2 distinctive brainwave patterns that we see on the EEG. K complexes, I don't care that you know about that, but sleep spindles are really important. I don't think you need to recognize what a sleep spindle looks like, but sleep spindles appear to be the electrographic representation, the brainwave representation of what the brain is doing to consolidate memories during sleep. So we can kind of think of the brain here as a computer, and the hard drive is really active now. We're consolidating memories, and the electrical representation of that are sleep spindles. Stage 3 and 4 are the deeper stages of sleep, and so that is just determined by how much delta activity. If more than half of the brainwave activity we're seeing is delta, then we know we're in stage 4 sleep. All right, so these are all examples of non-REM sleep. Okay, and during non-REM sleep, we have no eye movements, except when someone falls asleep. If you've ever watched someone fall asleep, their eyes roll back and forth slowly during that initial transition to sleep, and so that is part of stage 1. But otherwise, we don't see any eye movement activity. Okay, and when someone's asleep during any of these stages, they may move a little bit, but it's reduced, clearly. But key thing here is it's not absent. There's a little bit of muscle movement. Okay, we'll contrast that with REM sleep, where the eyes are moving a lot. That's why it's called rapid eye movement sleep. So we can see that on the electrooculogram, but there's muscle paralysis during REM sleep, which is a good thing, right? So if you're dreaming and we didn't have muscle paralysis, you would be doing all kinds of wild things. So the only muscles that are really active during REM sleep are eye activity and, of course, breathing muscles. We don't stop breathing during REM sleep. So here's an example, alpha rhythm. This is what we see during wakefulness. You can see this is slower. So someone is now into stage 1, stage 2 sleep, stage 3 and 4. We see the delta, very slow brainwave activity. Now, I mentioned 2 rhythms we see during stage 2, sleep spindles and Cape complexes. And so anytime we do an EEG, an EEG takes about 45 minutes to an hour, and someone is just lying there with their eyes closed. They frequently fall asleep, and so we can tell when someone's in stage 2 sleep by these distinctive patterns. But sleep spindles are the ones I want you to remember. Okay, so that is memory consolidation. All right, so when someone is awake, of course, we're going to see, muscle activity here on the EMG. You can't really make a lot out of the brainwave activity here, but the eyes are moving. Okay, and during REM sleep, again, we see lots of eye movement activity, but notice nothing from that submentalis muscle in the chin. Contrast this with non-REM sleep, where we don't have as much muscle activity as we do when someone is awake, but there's still movement. So this absence of movement is distinctive for REM sleep. Okay, and contrast eye movements here. During non-REM sleep, the eyes aren't moving much. Lots of eye movement here during REM sleep. All right, so here's a nice drawing that a student did for me just a couple of years ago to illustrate the different stages of sleep. And I'm sorry to insult all of you by putting it out to 8 hours, but there it is. So notice that when you fall asleep, you go pretty quickly down to stage 4 sleep. And so the deeper stages of sleep occur during the first third of the night. Okay? So notice that as we go throughout the night, sleep becomes lighter. All right? And so along with that, the periods of REM sleep get longer and longer. And that's why frequently you'll wake up and you'll have a dream that you remember, because REM sleep predominance gets longer during the last third of the night. Now, one thing that isn't really illustrated here, there we see 3 of these little spikes, but we actually wake up briefly many times throughout the night. These very brief awakenings, we're usually not aware of those or don't remember them in the morning, okay, but we can have lots and lots, especially during the last third of the night, of brief awakenings. 50% of sleep is stage 2. So I just kind of want to highlight here that a lot of the night, half of the night, is spent here in stage 2 sleep. So we have these cycles, and it can vary from individual to individual, 4 to 6 cycles between non-REM and REM stages of sleep. Again, the deeper stages are especially the first third of the night. REM increases towards the end of sleep. Okay. Again, we dream through all stages of sleep, but the really vivid ones that you'll remember are during REM sleep. And important that you remember that half of sleep is stage 2, which remember you want to associate with memory consolidation. So a lot of things happen just with normal aging. One occurs in teenagers. What are teenagers known as? And I suspect many of you still have this type of sleep, where teenagers are known for staying up late and having a really hard time getting out of bed in the morning. And that is actually a physiologic, biologic, normal change that happens in the brain during teenage years. And so there are lots of studies, even teenagers that have a nice normal sleep, that they tend to be more drowsy, a little foggy during the morning hours. So that's just something that occurs during teenage years. When I was a medical student, I could still sleep until 11 in the morning on the weekends, and there's not a chance I could do that now. So it's just a distinctive change. As people get older, they lose the deeper stages of sleep. Stage 3 and 4 may disappear completely in the elderly. Newborns, 50% of sleep is in REM sleep. And if you've ever watched a newborn sleep, the eyes are just going crazy. It almost looks like a seizure activity sometime. But REM sleep does diminish with age, so it stays at 25% from age 10 on, but in the elderly there can be a drop-off further in REM sleep. Overall, sleep efficiency declines with age. And I've frequently seen a board question of an older individual having poor quality of sleep at nighttime, waking up a lot, and the right answer is usually normal sleep of elderly. It's not really a pathological process that occurs normally as people get older. Okay, so with normal aging, there's just a reduced ability to what we call sleep like a baby. So please don't memorize this, but it is helpful to know, and I will show, if I'm seeing younger individuals, this kind of the amount of sleep, and we can just see that the requirements go down with age. Older individuals may do just fine on 5-6 hours of sleep. You will occasionally hear of rare individuals that say they need no sleep or very little sleep. That is really exceptionally uncommon and rare. So, this is kind of a good guideline to amount of sleep requirements that are needed. So teenagers, again, school is quite disruptive because of this. You have to get up at 6 in the morning or earlier to get to school, and that's why teenagers often are sleep deprived during the week and need to do a lot of extra weekend catch-up sleep. That's normal. Okay, so let's go through some different sleep disorders. First of all, insomnia, which by definition needs to result in daytime impairment of symptoms. And so, someone is exhausted or fatigued during the day. They need to have daytime symptoms. And so here are some different types of insomnia. One is quite unusual. It's called paradoxical insomnia or sleep misperception syndrome. And these are individuals that feel like they have a poor sleep quality at nighttime, but we bring them in, we do a sleep study, and they sleep perfectly throughout the entire night. And we ask the patient in the morning, "How was your night?" "Oh, it was horrible. I tossed and turned, couldn't sleep at all." And we're looking at, the polysomnography testing. It's perfectly normal. There's that condition. And so sometimes some cognitive behavioral therapy can help with a lot of these different conditions. Psychophysiological insomnia is something where there is an excessive concern with the ability to get to sleep. And so as you're starting to get drowsy and about ready to fall asleep, there is a recurring alerting thought in the brain. What if I can't get to sleep? And so that becomes then activating. This is often related to stress. And again, this is something where cognitive behavioral therapy can be quite helpful. Now, I mentioned depression is the most common cause of insomnia, and you need to know the difference between sleep insomnia between these two conditions. In anxiety, there's more difficulty getting to sleep at nighttime. Okay, this may relate here to the psychophysiological insomnia. Concern about getting to sleep, the thoughts just start going and you can't shut them down. Depression, on the other hand, classically results in early morning awakening. Patient gets to sleep all right, but then they wake up at 3 and can't get back to sleep. And so, especially in the elderly, where depression may not manifest as obviously, maybe it would in a younger individual. And so if we're screening for depression in the elderly, we would want to ask, how's your sleep at nighttime? Okay, so a lot of early morning awakening might suggest depression. Again, very important, we look at the patient's medications or substance abuse, alcohol, smoking, all of that's going to contribute to insomnia. And then many individuals just have horrible sleep hygiene. So sleep hygiene, one of the biggest factors here, if you have insomnia, one of the first things we'll recommend is to set up a regular sleep schedule. So if you have insomnia, it's not good to go to bed at 8 in the evening one night and then 2 a.m. the next day. You want to try to have a regular schedule for both going to bed and getting up. Also, alerting activities prior to sleep. So that could include screen time. I mean, looking at a bright iPhone, shutting down melatonin in the minutes before you fall asleep. If you don't have insomnia, no problem. But if you have difficulty sleeping, that is not healthy. Exercise is great, of course, but vigorous exercise right before going to sleep would not be the best. And I would just add here that you'd really want to consciously choose. If you have difficulty getting to sleep at nighttime, save 30, 40 minutes before you get to sleep and just decide, whatever it is that I'm worried about in life right now, I'm going to set a time maybe tomorrow. Well, I'll think about that and worry about it then. But I'm not going to allow myself to ruminate and think about those things before sleep. I'm going to make that relaxing time. So if you have insomnia, really you shouldn't take any caffeine after noon. Alcohol and cigarettes. Alcohol can facilitate getting to sleep, but oftentimes it triggers, can be alerting after a few hours, and patients wake up and then can't get back to sleep. And then when someone has insomnia, we really discourage the use of naps during the day. Okay, try to break that cycle by, it'll make you more tired when you go to bed at nighttime. And this can be difficult for a while, but try to break out of that and, just get your sleep when you're in bed at nighttime. So this is a list I have printed out actually that I give to patients of healthy sleep habits from the National Sleep Foundation. So these are just basic recommendations, but many patients are not doing any of these things. So the use of bed and bedroom, if you have insomnia, should really be for only sleep and sexual activity. Establish a regular routine. Don't have a big meal right before bed or drink too much close to bedtime just because you're going to have to get up and go to the bathroom. Again, that's more of an issue as you get older. You want to have a nice sleep-promoting environment. So generally on the cooler side, dark, something that produces kind of a background noise can be helpful. So a white noise machine. During the day, cut back on caffeine, especially afternoon. Alcohol and smoking are not good, especially, closer to bedtime. Exercise is great, but kind of a 3-hour window between exercise and sleep is probably the best. Avoid naps, especially later in the day. And then I give a patient, I actually had a medical student create for me a little form, a sleep diary, where the patient can put in, like if they napped or when they took caffeine, how the quality of their sleep is. And by recording all of these things, you can look at it and give the patient some advice on how things could be improved. Now, in terms of medications, I'll first go through the FDA-approved medications for insomnia. And so our first category are the GABA-A receptor modulators. And the classification here is completely non-helpful. So I won't ask you this. There are so-called benzodiazepine receptor agonists and non-benzodiazepine receptor agonists. And really there does not appear to be a difference, even though we have that different classification system. And so there are so many of these. Flurazepam, temazepam, zolpidem, you may have heard of Ambien, are just some of the common benzodiazepine medications. And really, if we use these, ideally they should be used just for short-term use, like someone's going through a stressful time, and a short course of these medications. The problem is most all of them have a long half-life, and so you're not just getting that short-term benefit, to get you to sleep and keep you to sleep for a few hours, and they cause rebound insomnia. So if you're taking these types of medications for months and months every night, and then you try to stop it, well, you're going to have a really hard time getting to sleep. And so there's a significant rebound effect. And also you may need to take more and more, a higher dose to get the same benefit over time. So generally this should just be for short-term use. So here's the GABA receptor. And here we have binding sites here for all of these different benzodiazepine type medications. Remember, barbiturates like phenobarbital also act on this channel. So you don't need to, please don't worry about any of the different medications here. I'm just listing some of the benzodiazepine medications to point out the kind of the long half-life that many of these have. Look at alcohol here, really short half-life. So I mentioned alcohol, a glass of wine before bed or a beer, it is sedating. It may help you get to sleep, but it doesn't last very long, and then patients will often wake up. And lots of these benzodiazepines really last a lot longer than, the 7 or 8 hours that are needed to help you sleep at nighttime. So they can have some effect during the morning. People can feel foggy, thick-headed when they wake up in the morning if they take these medications. Ramelteon is a melatonin receptor agonist. It's FDA approved for insomnia. Interestingly, melatonin is not FDA approved for insomnia. So this is something that can help for some patients. And then a medication called doxepin, which is a tricyclic antidepressant, but unlike the other tricyclic antidepressants we've talked about, like nortriptyline and amitriptyline, this has a lot of activation on the histamine receptor. So it can also be helpful for insomnia. Now you will see when you get out into the 3rd and 4th year, a lot of people use sedating type medications for sleep, like an antidepressant trazodone or even gabapentin, but these are really not indicated for sleep, but they're frequently used. Most over-the-counter medications for sleep have diphenhydramine, which is an antihistamine, okay, but that again lasts longer than just during the night's sleep. So we can have some morning thick-headedness with these medications. So I would just encourage you to walk through a pharmacy, look at the different medications. So a lot of the sleep medications, oh, there it is, diphenhydramine. And hundreds of unregulated compounds. Most of these are placebo. But hey, if it's harmless and if it's helping someone sleep at nighttime, I'm not going to argue with a patient and saying, they're getting a placebo benefit. If it's harmless, no problem if it's helping. Now our next category are sleep-related movement disorders. Restless leg syndrome, extremely common. And one thing that convinces me that someone has restless leg syndrome is they will say, it only happens when I lie flat, and then I have this feeling in my legs it's really hard to describe. And when I hear that, I'm almost a believer immediately it's restless leg syndrome, because it is hard to describe. It can be kind of a creepy, crawly, achy feeling in the legs, and an incredible urge to stretch the legs. And when patients say they stretch their legs, they dorsiflex or plantarflex their foot, it feels better for a few minutes and then it comes back. Same thing if they walk around a little bit, it goes away. But then when they go back and lie down again, the feeling in the legs comes back. So this runs in family, and there is a problem here with iron deposition. So we know there are low levels of iron in the basal ganglia in these individuals, and so when you see someone with restless leg syndrome, don't just jump right to treatment. We should also always check them for an iron deficiency, which we can do by checking a ferritin level. So that's kind of knee-jerk. That should always be done, because if you correct that, if they have an iron deficiency, then you don't need to give them additional medications. Now, in previous years, I have emphasized the use of dopamine agonists, like we talked about in Parkinson's disease, pramipexole and ropinirole. And those are very effective. But as time has gone on, we're learning about something known as augmentation, where you're giving a patient pramipexole before they go to bed, and it's really helping. Over time, you need to give them a bit more and a bit more, and then you notice that the restless leg syndrome is actually getting worse, and so you increase the pramipexole more, and it actually worsens it. And so that process is referred to as augmentation. And it commonly happens when we use these dopamine agonists. And so that's why now we see more neurologists using first a long-acting form of gabapentin. It's called gabapentin enacarbil, which also works, maybe not quite as strong as a dopamine agonist, but we don't get into augmentation with this medication. And so these are our two most effective medications for restless leg syndrome. Just be aware, we certainly don't want to overshoot and give a patient too much of a dopamine agonist, or we may get into augmentation. Remember dopamine agonists I mentioned about impulse control disorder, gambling, and all of that we see with Parkinson's. That can also happen when you give it for a condition like restless leg syndrome. So we need to ask about those issues anytime we prescribe a dopamine agonist. Now, 80% of patients with restless leg syndrome also have periodic limb movements of sleep. The older term is nocturnal myoclonus. And so these are myoclonic jerks that occasionally can be alerting for the patient and can disturb their quality of sleep. It's usually the spouse that is more bothered by this, because middle of the night, all of a sudden the whole bed jerks. And so oftentimes the spouse will come in, you've got to do something about this. So this can be difficult to treat. It can also respond to the medications that we use for restless legs syndrome, somewhat. Our next category are the primary hypersomnias of central origin, and probably almost of anything in this handout, there are more board questions on narcolepsy than anything else. And so think of narcolepsy as a problem with REM intrusion into wakefulness. So what happens during REM sleep? Well, this is dream sleep. This is when you have muscle paralysis. And so we're going to see that intruding into wakefulness. So more than 90% of individuals with narcolepsy have this HLA allele here. And so narcolepsy has a bimodal distribution with onset usually around 15 or 35. And so what happens in narcolepsy is we have a dramatic reduction in the number of orexin-producing neurons in the hypothalamus. And so it's felt that there is some antigen, and this can be infectious. For example, during the H1N1 influenza in 2010, there was an outbreak of narcolepsy. And so if we have an antigen that combines with the HLA molecule, the protein, then this causes a sort of a modulation of T-cell receptors, which leads to a dropout in the orexin-producing neurons. This is hypocretin. Remember, that's the same thing as orexin. So in terms of pathophysiology, there's some infectious, usually antigen, that seems to trigger this in a genetically prone population. And when you lose those orexin neurons, which remember are active when you are active and help to keep us awake, then these individuals have excessive daytime somnolence. I mentioned it's impossible to fall asleep standing up because of the orexin neuron activity. Well, I have patients with narcolepsy that can fall asleep standing up. And so these individuals have excessive daytime somnolence. We've had a few medical students over the years that have narcolepsy and just slip right into sleep, during anything that's a little sedentary, boring lecture, or when I go out to the waiting room to get a patient that has narcolepsy, just sitting there, it's just impossible to stay awake. Okay, but remember, it's REM intrusion, so they slip right into REM sleep. They go right into the dream-like stages of sleep. What happens when you fall asleep? You lose muscle tone, and that describes cataplexy. So these individuals have episodes during the day where usually something that is stimulatory, I have patients who will come in and tell me a joke, and then they'll start laughing at their own joke, and then they'll lose muscle tone and will just collapse and fall to the floor. All right, so cataplexy is almost always present in narcolepsy. A lot of people, think about narcolepsy when someone is drowsy during the day and they fall asleep, but there are a lot of reasons for that. So really we want to find these other features to confirm that the patient has narcolepsy. I used to treat a lady for years who had narcolepsy, and she loved to go bowling with friends. And when you bowl, you tell jokes and things like that, and she kept falling because of the loss of muscle tone. They don't lose consciousness. It's not like a seizure, but they just need to hopefully learn to fall in a way that they don't hurt themselves. Sleep paralysis is something that usually happens on waking up in the morning. And so, again, it's REM intrusion into wakefulness. And so they have the muscle paralysis from REM sleep, but yet they're awake. And this can be terrifying. In fact, I would bet this is so common just for a normal individual to have one or two of these episodes that there are probably a few of you listening to this lecture that have had this. So if you've had one of these or two of these in your life, you don't have narcolepsy. Occasionally that can just be a normal process. Likewise, hallucinations, either on falling asleep or on waking up. It's REM intrusion into wakefulness. So you have a dream, essentially, when you're awake. So hypnagogic is on falling asleep, hypnopompic is waking up. And so, your eyes are open, you're awake, and you see like a vision on the wall or something like that. So patients that have narcolepsy will commonly have that. And then, although this is not like one of the 4 cardinal features of narcolepsy, it probably should be added because quality of sleep is poor at nighttime in patients with narcolepsy. And they can even look a little bit like that REM sleep behavior disorder at nighttime. In fact, I had a student not too long ago was very concerned he had REM sleep behavior disorder, but it was probably narcolepsy, okay, because that can have a similar, sometimes just poor quality, maybe a little bit of acting out of dreams at nighttime, that kind of thing. So how do we diagnose narcolepsy? Well, one of the most helpful tests is to do what's known as a multiple sleep latency test. We bring the patient in to a nice, quiet, dark room, and we hook them up, like we do with the polysomnogram. We look at the EEG activity. And patients with narcolepsy in that environment are going to fall asleep quickly, okay, usually within 10 minutes. Now, I'll bet a number of individuals, though, could very easily fall asleep within 10 minutes if you lie down in a dark room. But one difference in narcolepsy is you can wake them up, and then you walk into the other room, and they fall right back asleep again. Okay, the other difference is in narcolepsy, they go right into REM sleep. So remember how we could diagnose that on the polysomnography testing. Lots of eye movements, no submentalis muscle activity in the chin, and there are brainwave features, EEG features, that I don't think you need to know about that can suggest someone is in REM sleep. So how do we treat narcolepsy? I really only want you to know about one medication for this. We can use amphetamine-type medications to keep patients awake during the day, but obviously that can have some really undesirable consequences. And so I would like you to know about this medication, modafinil, which is pretty gentle, really. And it seems to increase the neurotransmitters that are involved in the ascending activating system like norepinephrine, dopamine, histamine. And so this is kind of a nice option to have that can facilitate wakefulness during the day. We will use tricyclic antidepressants or SSRIs for the cataplexy. So if someone's having lots of cataplexy, we have a variety of different medications that work well for that. Now, in terms of sleep disordered breathing, sleep apnea, exceptionally common here. So, 1 out of 4 men have sleep apnea. And this is associated with obesity and large throats, a small chin, micrognathia, the larger posterior pharyngeal tissue, tonsils, adenoids, uvula, and so on. And so you don't need to know the different stages here. There's a Friedman scale where you just have a patient open their mouth. And so this would be the most advanced, where we really can not see the soft palate at all. If we see only the hard palate visible, then this is somewhat at increased risk for sleep apnea. So the features of sleep apnea, it's helpful if there's a spouse that can tell you they have loud snoring and episodes at nighttime when they stop breathing. Okay, and this is exhausting. People with sleep apnea wake up hundreds of times during the night because of these apnea episodes, and so they have a lot of daytime hypersomnolence. They can't stay awake during the day. And remember, morning headaches are a classic feature of sleep apnea. Sleep apnea is just not healthy. In other courses, you will learn about all the medical complications that go along with sleep apnea. So in terms of diagnosis, here we have airflow. So we have abdominal effort and thoracic effort, to open the airway. And so one thing that's a little bit confusing, we can measure during the sleep study the oxygen saturation. So the patient is breathing here, okay, but because of the slow, the pulmonary circulation time, the oxygen desaturation lags behind when someone takes a breath. So you take a breath here, and the oxygen, goes up here. So the desaturation and oxygenation does not correspond really with when you take a breath. But the main thing that will help us, confirm the patient has sleep apnea is you can measure the contractions in the abdomen and the thorax. And so they're trying to overcome the closed throat. And so we get a lot of efforts, and they have to get stronger and stronger. And then finally the airway opens up, the patient breathes, and then you need a lot of effort again here. So this is kind of the key thing that tells us they have an obstructive sleep apnea. So one of the most helpful treatments for this is continuous positive airway pressure. Patient wears a mask that delivers some increased pressure to help to keep the throat open. Many individuals just hate wearing this, though. So even though it can be helpful, the CPAP can just mechanically can make it difficult for patients to sleep. So weight loss, can be helpful. And if a patient has a lot of posterior pharyngeal tissue, tonsils, we can have ear, nose, and throat remove those to try to facilitate airway opening. Central sleep apnea is much, much less common. Okay, now we have problems with the central areas in the brain that stimulate breathing. Okay, so you can have damage to the lower brain stem or sometimes a severe upper cervical cord lesion, but these would be quite uncommon. The only condition I've told you about in this course that relates to a central sleep apnea is myotonic dystrophy. And notice the difference here. In between breaths, since there's no obstruction really, we have no abdominal or thoracic effort to breathe. We're just losing that central drive to breathe from the lower brainstem areas. Now, in terms of parasomnias, somnambulism we see mainly in kids, tends to go away with age. This occurs during the deeper stages of sleep, and usually we have a family history of this. So my sister was a sleepwalker, and one of my sons was as well. And so because they're during the deeper stages of sleep, these individuals usually are not aware of it in the morning. And so our son used to come into our bedroom and he would just fiddle around with things, maybe try to turn the TV on, and kind of has a foggy look. You'd talk to him and he wouldn't respond. And so, we would just try to gently guide him back into his bedroom. Usually goes away, fortunately. So it doesn't require treatment, and you just need to do things to try to prevent injury during these episodes. REM sleep behavior disorder, we've already talked about quite a lot. Remember, you lose the muscle paralysis during REM sleep. So these are usually men that will develop one of the synucleinopathies, diffuse Lewy body, Parkinson's, or multisystem atrophy. Okay, and so again, it's often the spouse that will tell you about this initially, that they're very violent, shaking at nighttime. Okay, and here was a study not too long ago that looked at individuals who had REM sleep behavior disorder, and just noticed that over a 14-year period of time, the number of patients who did not develop a neurologic disease, one of those three synucleinopathies, was only 9%. So 91% over this 14-year period of time eventually developed a synucleinopathy. So safety is a big issue because of the thrashing around, so there are different things that can be done for that. A long-acting benzodiazepine for years had been the drug of choice for REM sleep behavior disorder, but in the last 10 years, it's known that melatonin is actually very helpful. Melatonin is so gentle. So this is always our first-line treatment for REM sleep behavior disorder. Often that works very well. And then you may need to add a low dose of clonazepam if you're not getting adequate response with melatonin. Night terrors, also during the deeper stages of sleep. So these are usually children that just wake up screaming, terrified. And because it's the deeper stages of sleep, they're not going to remember it in the morning, but the parents come in, what's going on, so they're just sweating, heart is racing, very intense, and then, the parents will get them back to sleep. Parents have a hard time getting back to sleep after that, but to contrast that with a nightmare, this is during REM sleep, right? The child is going to remember the nightmare because it's in a lighter stage of sleep. A nightmare can be intense, but it's not nearly as intense as a night terror. They can be calm, they can be reassured, they're talking with the parents when they come into the bedroom, and they can remember the dream and talk about it in the morning. Nocturnal enuresis or bedwetting is again a deeper stage sleep disorder, and this is often just a maturational lag of the central nervous system, where over 6 months the child will stop bedwetting. There are some medications that can be helpful for that if needed. Sometimes we'll see bedwetting related to a psychological process. The parents are getting a divorce or something like that, and so you always want to ask about that if you're a pediatrician in a child with nocturnal enuresis. And then finally, we have the circadian rhythm sleep disorders, where we have a misalignment between the circadian rhythm 24-hour cycle and what's going on in the external environment. And so two of these, the advanced sleep phase disorder, is something that we see usually in the elderly, where now they're needing to go to bed at a socially not appropriate time. They're exhausted at 7 o'clock in the evening and they have to sleep. And then they're waking up at 2 in the morning. So this is kind of a spectrum. I mean, in general, as people get older, they prefer to go to bed earlier. Contrast that with delayed sleep phase disorder. These are like the teenagers who can't get to sleep at nighttime. They want to stay up late. So that's normal. But in a pathologic condition, and I have some patients that say they just cannot sleep until 2, 3 in the morning. And then they want to sleep until, 10 or 11 in the morning. So that's abnormal, and we would call that a delayed sleep phase disorder. And then, of course, jet lag disorder, which tends to be worse when traveling east, because when you travel east, your circadian rhythms need to advance forward, which is harder to do. And it's going to be more prominent with the more time zones that you cross. And so your circadian rhythm is out of sync with the light-dark cycles and the new environment that you're at. And so symptoms are, many of you have experienced this, I'm sure. You're just kind of wiped out, a little irritable, sleepy, you want to take naps. So the best thing you can do, if you're flying to Europe or something like that, is to try to get your circadian rhythm reset. And so you want to get a lot of light stimulation. Okay, that would shorten how long the jet lag is going to last. So be out in the sunlight when you're there as much as you can. Try to get that on-off production of melatonin in sync with the new environment. Again, try to eat meals at times that are appropriate for the new place, where you're visiting. That will help as well. Melatonin, taken before it is appropriate to go to sleep in the new environment, can be helpful. And a little caffeine, well, depending on how much caffeine you drink regularly, but when you get over there and it's light, let's say you arrive at 2 in the afternoon, well, that would be actually okay. Take a little caffeine, get a lot of sun exposure, try to stay up. Don't take naps. Try to stay up until 8 or 9 in the evening, and you can usually pretty easily reset those circadian rhythms.